Good afternoon, everyone. I'm calling the meeting on the Committee of Health and Human Service Policy to order. Okay, is it on? Okay, good. There is a quorum present. May I have a motion to approve the minutes for Tuesday, February the 19th?
So moved.
Representative Albright moves approval of the minutes for Tuesday, February the 19th. Any discussion? Hearing none, those in favor say aye. Aye. Those opposed? The motion prevails and the minutes for Tuesday, February the 19th are approved. Members, today we have 4 bills to be heard in this committee. I expect that it's possible that we may go past 4:15, our time that is allotted for us here. We have caucus at 4:15. So it is my thought that we will be coming back this evening at the call of the chair. We'll recess and then come back into this room after caucus. So I do want to apologize for anyone who traveled in the snow. It's pretty bad outside. And if at all possible, I would do my best to get as many folks as possible to testify today if you cannot come back. And if you cannot come back, please check in with my CA here, Patrick, and we can see what it is that we can do. And I can't promise anything. It just depends on the bills themselves and how many testifiers and time and processes we take with each bill. So in saying that, our first bill is House File 733 with Representative Tabke. So the chair moves that House File 733 be recommended for re-referral to the Committee on Ways and Means. We have the bill before the committee. Welcome, Representative Tabke. Can you please present your bill?
Thank you, Madam Chair and members. I really appreciate your time and for being here today. My first time, so obligatory cookies are coming around. So we can go with that, and we'll keep it short today. So thank you, Chair Moran and members. House File 733 is an initiative of the Minnesota Sheriff's Association to authorize the use of low-dose X-ray body scanning devices for the purpose of scanning incoming inmates to correctional facilities for concealed weapons, drugs, communication devices, and other contraband that pose serious risks to the safety and security of jail staff and inmates. The House of Representatives passed similar language last year and was included in the omnibus bill that was vetoed by Governor Dayton in 2018. There was no opposition to this bill. The language contained in House File 733 is the exact same language contained in the bill vetoed last year. So the Minnesota Department of Health regulates X-ray devices used in Minnesota. Current law appears to limit the use of these scanners to medical settings, and this bill would authorize their use in local and state correctional facilities. So it will help to make sure that we are much safer in our local jails and prisons. And so with me today is Commander Dave Patchell of the Anoka County Sheriff's Office and Warden Tracy Belts from the Shakopee, from my district, from the Shakopee Women's Correctional Facility, and they will testify and answer any questions that we have. And so I also believe, and there are representatives from the Department of Health and the Department of Corrections here if we have any more technical questions for them that I am completely unable to answer. So thank you very much, Madam Chair.
Thank you so much, Representative. To the first testifier, please, welcome to the committee. Please introduce yourself and who you are and give us your testimony.
Thank you, Madam Chair, committee members. My name is David Paschal. I'm a commander with the Anoka County Sheriff's Office, and I oversee jail operations. We are here to ask for your support on this bill because in local jails and correctional facilities, we are facing a contraband crisis. And that's not a word I use lightly. Contraband has been something we've dealt with ever since there's been jails and prisons, but it has gotten much worse in the last 7 to 10 years. When I first started in this line of work, we would have contraband coming in, but it was relatively infrequently, and the attempts to introduce contraband were not very sophisticated. That has turned around. In the last 9 years, I've seen almost a 400% increase in the amount of drugs I've found in my jail alone. And we are not catching everything. That's the problem. When we first started noticing an uptick in drugs coming into our facility, we started looking at ways we could try and find them. We increased the number of searches. We now do 3 searches when a person comes into custody. Once in the garage to find big contraband. Once they come in the jail, we then do a metal detector search to try and find weapons. And then finally, we do a really close pat search to find items. To help us find drugs that are coming in through the mail or drugs that have gotten into the jail, we use drug dogs to scan our mail and also periodically to walk through our facility to find drugs. The problem is we are still finding drugs in our jail. We know through developed intelligence, talking to the people that smuggle them in, the way they're getting it in, and they're getting it in by hiding it inside their body. That is something that none of our current tools will detect or find. The problem with this, not just is that the drugs are coming in, it's the risk it presents. It presents a risk to the person that's smuggling it in because they usually will ingest it in like a latex balloon or something like that. If that leaks, they will have a horrible time. They could actually die from that, from overdose of drugs. If they get it into the jail and sell it to somebody else, that can cause problems. And if staff come into contact with the item, they can overdose too. In my jail alone in the last 6 months, I've sent 2 people out on red lights and sirens with an ambulance because they managed to overdose once they got in my jail. One of my peers at another correctional facility, 2 of his officers were sent to the hospital because they came across a white powder in the course of their duties and they were badly affected by it. I'm not aware of any deaths due to this, but it's only a matter of time before we have them. These low-dose ionizing scanners, they're very much similar in many ways to what we walk through when we go to the airport, but they would be a crucial tool for us because they would help us detect items that are hidden internally within a person's body. Thank you.
Thank you so much. And give another testifier, please introduce yourself.
Thank you, Madam Chair and members of the committee. I'm Tracy Belts. I'm the warden at Shakopee Correctional Facility. Thank you for allowing me to testify. I echo the sentiments that was just expressed. For our department, it would be hugely beneficial to have a scanning device that we could detect contraband that are hidden on or in a person as they come in. We recently had a very similar situation within the last couple of weeks where a woman was sent out to the hospital after exhibiting almost seizure-like kind of behaviors. She had been with us for 3 weeks and was found to be positive on drugs. And if you're in there for 3 weeks, there's only one way you're getting them in, and that's typically smuggling them inside or on a person. The benefits are not just within the keeping of the safer facility, which is paramount, but we're also concerned about the women themselves when they have things that are on them or in them that they should not have. We can treat them medically. Right now, it's undetectable. From my personal vantage point, I'm dealing with the only female facility, and we do things a little bit different there. We have for example, children's visits that they are allowed to come inside the prison. I am concerned about drugs inside of our facilities when I've got kids that are visiting their mom. Additionally, it's a benefit to our staff. That's something that people don't often think about, but staff don't like going through the process of performing an unclothed body search. This equipment, this tool would give us the opportunity to do the search the way that we need to do it with them having a gown over them. So working with the female population, there is a huge history of trauma, abuse issues that the women have gone through, and every time you have to do a search like we do, it causes more trauma issues. And so the benefits are all around: safer facilities, safer for the women themselves, safer for the people that work there. The other big issue is that if we don't have safe prisons, we can't work on our mission to give them programming that helps them get out and stay out. And that is of paramount importance to us. We want to reduce recidivism, and to do that, you have to have a foundation of safe, secure facilities. Keeping contraband out aids in that process. Thank you.
Thank you so much, Warden Belt, for coming out to testify today. Do we have anyone else from the audience who would like to testify on House File 733? Okay. Any discussion from the committee? Representative Albright.
Thank you, Madam Chair, and this would be for the member from Shakopee. In subdivision 9 of your bill, you talk about an exemption available to the employees of correctional facilities, and you're exempting them from subdivisions 5 and 6, which speak to the training aspect for individuals operating these systems. So what training would they possess that would avail them of understanding how to operate the systems?
Yes, thank you, Madam Chair and Representative Albright. Yeah, this is a very good question, and one that I also asked as we were first talking about this. But there's extensive training, obviously, that needs to go into these types of devices to be used, and a better person to answer that will be from the Health Department. So I would like to call them down to give a clear technical answer that I'm unable to provide.
Hello, and welcome to the committee. Please introduce yourself and proceed with your testimony.
Thank you, Madam Chair. My name is Teresa Parrington. I'm the X-ray Program Supervisor here for the Minnesota Department of Health. To answer the question in regards to the exemption, there is no national recognized guideline standard for these individuals to take a test for training. That's why they're exempt from it. However, there are national recognized guidelines that were developed from the Health Physics Society back in 2009 that has numerous amount of training that is required for the individuals who are operating the equipment.
Representative Albright.
Thank you, Madam Chair. And I'm sure that in the context of that training, we're also talking about the safety of the operators, given the fact that there's low doses of X-ray being emitted by these machines on a regular basis, probably per day. And so then my follow-on is, and maybe you can answer this, is under subdivision 9, paragraph B, where you're talking about in lines 2.18, it says permanent rules adopted by the commissioner governing security screening systems. So could you just elaborate for the members of committee in terms of what that really pertains to?
To the testifier.
Madam, yes. Madam Chair, committee members, can you repeat that question? I want to make sure I'm in the correct area.
I don't have a problem with the language, I just don't understand it. It suggests on line 2.18, this paragraph expires, I'm going up the line above it. This paragraph expires on December 31st of the year that the permanent rules adopted by the commissioner governing security screening systems is published in the state registrar. What does that mean?
Please proceed.
Okay, Madam Chair, committee members, what I can answer this is currently right now we have rules and regulations that prohibit the use of this use of equipment because our rules were developed and adopted in 2008. Since then, in 2009, Health Physics Society has come out with national recognized guidelines to safely regulate these types of equipments. Currently right now there's 13 states that are currently regulating this in the states. What 217 to 219 means is currently right now our rules don't have anything in there right now to protect these types of equipment. So what we plan to do is utilize a variance to use these national recognized guidelines until our rules are adopted to allow this use of the equipment. There are requirements for the inmates to get scanned to safely use in these national recognized guidelines that limits them to how many times they can actually get scanned. There's also requirements in there that allows for facilities to give the inmates documentation on what kind of screening that they just had. So they're also notifying them as well.
Thank you, Madam Chair.
Thank you. Chair Liebling.
Thank you, Madam Chair, and I appreciate the questions from Representative Albright because this is a health committee, and so while I think the case that was made by the other testifiers is pretty compelling about the need and that there are some health aspects to that too, I really did want to ask about, the safety of this, and especially the Warden Belt said that children might be screened. I think that was what she was saying. No, Representative Tabke, you're shaking your head. That wouldn't be part of it. So that kind of raised a bit of a red flag for me if children would be going through this equipment. But to the testifier from the Department of Health, it sounds like, in the way you answered Representative Albright, that there are some rules around this and that the department is really monitoring this for safety. That's really my concern here in the Health Committee. Is that accurate?
Mrs. Burrington.
Madam Chair, committee members, yes, that is accurate. We intend to use this variance to allow the safe use of this equipment by utilizing the national recognized guidelines that were developed by the Health Physics Society to safely regulate them until our rules are adopted.
Okay, thank you very much.
Representative Mann.
Thank you, Madam Chair. I just had a question about what kind of equipment we're talking about, because you said you'd be able to see inside people's stomachs?
Mrs. Burrington.
Madam Chair, committee members, yes, there are two types of screening systems. One is where you can just get the image on the outside, which is similar to what you would see if you were going through the airport. You would just get to see the surface. These types of equipment that they're referencing actually it's like an x-ray, where if you would get a regular general chest x-ray, you would actually visually be able to see within inside of the body.
Representative Mann.
Okay. But things like a bag of cocaine that has no calcium or no, it's like soft tissue, you can still see that on this particular scan?
Mrs. Burrington.
Madam Chair, committee members, from my understanding, yes.
Representative Halverson.
Thank you, Madam Chair. Representative Tabke, maybe this is for the Department of Health. So you said there was a limitation on how many times a person can be scanned. I, of course, am always very worried about how much radiation somebody is going to be exposed to. Can you tell me what does that look like? And is there a dose per screen? Every time they're scanned, is there a dose of radiation? I want to know the measurement of what they're actually being exposed to.
Mrs. Burrington.
Madam Chair, committee members, I'm just going to grab that information. By looking at the information that I have from these Health Physics Society, one individual can be scanned 2 times per day, 19 times in a week, 83 times in a month, and 1,000 times in 1 year. To answer your question in regards to millirem, in 1 day, when I'm referencing the 2 times per day, it is, you can receive 1 millirem in 1 day, which would equal the 2 times a day. When it comes to the 12-month period, it's 25 millirem in a year.
And does that go by thank you, Madam Chair, does that go by national standards set within that guideline that you would be falling within that exposure?
Mrs. Burrington.
Madam Chair, committee members, yes, it is.
Okay, and can I find that online? You
Yes.
think, okay.
Well, this type of ANSI standard, you can buy it online for $50.
Okay,
So yes, it is available online.
thank you, Madam Chair.
Representative Morrison.
Thank you, Madam Chair. I think this is for Warden Belts. I'm wondering if there's a protocol in place if someone declined to be screened. That sounds like a safe level of radiation for a pregnant woman, for example, but if a pregnant woman declined to be screened, do you then offer a manual screening, or what goes on?
Warden Bell.
Madam Chair, members of the committee, that is an exceptional question that I cannot answer at this time. I would have to consult with we have a Department of Health within our department, and I would have to go to the director and talk to them about what that would look like. We can always revert back to what we do now, which is the unclothed. Yeah.
Is there any further questions from members? All right, so being no further discussion, Representative Schultz. Representative Albright. All right.
No, you made the motion.
You moved the motion. Representative Albright, please.
Madam Chair, I move the minutes.
I did that, okay. We're okay. So being no further discussion, the chair renews her motion that House File 733 be recommended for re-referral to the Committee on Ways and Means. All in favor say aye. Aye. All opposed? The motion prevails and House File 733 is recommended for re-referral to the Committee on Ways and Means. Thank you so much.
Thank you very much, Madam
Thank
Chair.
you all so much, and be safe driving back. All right, our next bill before the committee is House File 85, for Representative Brand. The chair moves House File 85 to be recommended for placement on the general register. We have the bill before the committee. Welcome, Representative Brand. Please present your bill.
Yes, thank you, Madam Chair. Thank you, members of the committee. I am here to propose legislation in front of the committee today, which was included in the 2018 budget bill. This proposal would direct the State Emergency Medical Services Regulatory Board to propose guidelines for EMT, AEMTs, and paramedics to assist a patient in the administration of time-sensitive medication. Although these guidelines are available broadly through the state now, this proposal would work to assure all EMS services had the same guidelines and information across the state. The A2 amendment, which I've also included before you, would remove Section B of the bill that brought concerns from the Minnesota Nurses Association over care planning by EMTs and the skill required to do that. At this point, I've not heard any additional opposition to the bill. And with me today, I've got a couple of people and that I'd also like to have testify.
Before we testify to begin, I need someone to move the A2 authors amendment.
So moved, Madam Chair.
Thank you, Chair Liebman. All in favor, say aye.
Aye.
All opposed? Any discussion? The motion prevails and the amendment is adopted. Representative Brand, your amendment has been added on to your original bill.
Thank you.
To the testifier, welcome to the committee. Please introduce yourself and tell us a little bit about who you are and why you're here today.
Hi, my name is Bailey, and my adrenal glands don't work like other kids. I like horses and American Girl stuff. I have to be careful because if I get hurt or sick, I get a shot, then I go to the hospital.
Can she repeat her name for us? What's your name?
Bailey
Bailey, what's your last name?
Johnson.
Johnson. Welcome, Bailey Johnson. Thank you.
And I'm Bailey's mom. Thank you, Madam Chair and committee. Bailey has adrenal insufficiency where her adrenal glands don't produce sufficient amounts of cortisol. Cortisol is the hormone that helps maintain life-sustaining functions such as regulating blood pressure, blood sugar, and heart muscle tone. Adrenal insufficiency can occur for a variety of reasons. Bailey's comes from a genetic disease that she had when she was born called congenital adrenal hyperplasia. Bailey was diagnosed when she was just 5 days old. She must take medication several times a day, every single day for the rest of her life. In times of stress, Bailey needs extra cortisol. A stressor for Bailey might be something that we would consider harmless or nuisance, such as strep throat and ear infection, or even if we get a dental filling. Other stressors are dehydration, illness, broken bones, or infections. Without immediate treatment, something as common as vomiting or diarrhea could very quickly trigger an adrenal crisis. Adrenal crisis is life-threatening. It requires immediate treatment in the form of a specific drug that Bailey has with her at all times. Delayed treatment of even as little as 30 minutes could have catastrophic results. When Bailey was diagnosed, we were told by her care team that Minnesota does not have protocols in place to address adrenal insufficiency in emergencies. We are advised to take precautionary measures because a call to 911 didn't necessarily mean that Bailey would get the immediate treatment that she needs. Therefore, we have always been proactive in her care. She wears a medical bracelet. She has a seatbelt cover that contains all of her information. She carries an emergency kit with her wherever she goes. We have medicine in a marked cabinet at home. We have medicine at school, at her dad's work, at my mom's work, in my purse. We have it everywhere at all times. Bailey's brave older brother, who is just 11, knows where Bailey's medicine is, where it's located and when she needs it. Just this last spring, he had to use that knowledge to help Bailey when she was sick and in the care of somebody else. Bailey's teachers train yearly on how to help Bailey when she's sick. Our address is flagged in the 911 system, and every year we share Bailey's needs with our local fire and rescue. Bailey has an emergency care plan with our local ambulance service, and she has a copy of an emergency letter on file at our local ER. So as you can see, we're prepared as much as we could be, and we felt safe. In the summer of 2016, we had an incident that brought us to realize that we cannot be the only ones equipped to protect Bailey. We went to an outdoor event in very rural Minnesota, and Bailey became sick and was lethargic. We gave her medicine as directed, but she didn't respond like we thought she would. She was in crisis. In a panic and away from home, we asked the ambulance crew that was there to help. We told them what Bailey had, what her needs were, and showed them her emergency care plan. By no fault of their own, they were unable to help and sent us on our way. On that drive home, it became crystal clear to us that all of our preparedness was not enough. We left there knowing that if we had an accident on the way home, that very crew could be the one to come to our aid. We became acutely aware that in any instance, anywhere in the state of Minnesota, if her dad or I were unable to help Bailey, no one might be able to help Bailey. She could die with her specific instructions and her life-saving medications within reach. So despite all of our planning, we do not drop Bailey off at basketball or gymnastics practices like other parents do to run errands. Either her dad or I go on out-of-town field trips. She doesn't even ride a school bus. Birthday parties, play dates, and babysitters are a huge leap of faith. Now Bailey's coming to an age where she wants to be in everything in school, all the extracurriculars, all the sports, she wants it all. We've already had to tell her no because some of it is some things where neither her dad nor I could readily be available for her just in case. We are thankful for the heroes in our life, like our local fire and rescue in small Cortland, Minnesota, Bailey's teachers at St. Paul's Lutheran School, the Alina Ambulance Service, all of whom recognize the urgent need Bailey has when she's in crisis. We also know that EMS are heroes too. We are asking that you please give these heroes the tools that they need to save people like Bailey in an urgent medical situation. Please give Bailey another set of heroes. Please support Bill HF 85.
Madam Chair, members, Buck McAlpin here on behalf of the Minnesota Ambulance Association. We worked last year with the family and Representative Johnson and Senator Frentz over in the Senate on this legislation. It was included in the budget bill. It was vetoed. We've done some work on it since then and think it's a better bill, working with some concerns with the nurses and the Emergency Services Regulatory Board on a little provision with care plans, and there was some good feedback. But lots of this is offered around the state today with our ambulances. But we feel working with our partners at the State EMS Board, we can do a better job of making sure everybody in Minnesota, even probably our small rural ambulance services, have access to the same guidelines our big ones like Alina do that you just mentioned a minute ago. So we're in support of the bill, Madam Chair and members.
Thank you so much. Yes, please introduce yourself.
Thank you, Madam Chair. Members of the committee, my name is Anthony Spector, and I'm the Executive Director of the Emergency Medical Services Regulatory Board. I'm here to testify that as the bill is as amended, the EMS Regulatory Board does not oppose and does support the amended bill to move forward. And I'm here to answer any questions.
That is awesome. Thank you. Is there anyone else in the audience who would like to testify on House File 85? Members, any questions? Representative Albright.
Thank you, Madam Chair. And to the author, to the testifiers on line 1.12, it talks about the intention to treat adrenal insufficiency, but it also includes other rare conditions. And I'm just wondering if either of the two testifiers could just lay out for us maybe the commonality of those ones that might occur in the field.
Please.
Yep, Madam Chair, Representative Albright. That came out of concerns from the medical directors and the legal about, we just didn't want to focus on one rare condition. There's, I believe, the Atlanta medical directors said there could be over 400 of them. So we wanted to be sure that our guidelines focused on not just the adrenal issue, but hemophilia, that the paramedics and EMTs and AMTs were ready to respond to everything.
Representative Albright.
Thank you, Madam Chair.
Okay, Representative Edison.
Thank you, Madam Chair. So with, I'm sorry, I apologize. So to the mom, when your daughter was having this incident, and you were in rural Minnesota, when you went to the EMTs and asked them to help, and Representative Tabke, you can jump in if you would like. This law essentially is going to allow them to be able to help you because they said they could not help you with prescriptions. Could you just give me a little bit more information on that?
Mrs. Johnson.
Oh, sorry. We just went to them and asked, if they would review her letter and, let us know if we were doing the right thing because we hadn't had anything like that arise before. And we knew what the plan of action was and we left there. But as we left, we knew that if we were in a car accident, that if they came to our aid, that if they were the ones that showed up and her dad or I couldn't administer her medication, we knew that they probably couldn't either. So Bailey was fine, of course. We took her where she needed to be. And does that answer your question?
Okay, so I guess, thank you, Madam Chair. I guess Representative Tapp, I keep calling you Tapp because I was up there. Representative Brand, this law would allow the paramedic then to have a plan for her. Will she also have a card? Is that how, I guess I'm just trying to make sure I understand how it's going to work.
Certainly. So there was, Madam Chair, Representative Edelson, there was some concern about the planning part of it, and so that is not part of this bill. That was the A2 amendment that actually removed that part of this bill. But what it does is it allows, from the liability standpoint, allows EMS professionals, AMTs, paramedics to actually administer the shot. Because when you think about it, there's this concept of a golden hour. These are golden minutes. And so if this isn't administered right away, it could be tragic.
Thank you, Madam Chair.
Chair Leafling.
Thanks, Madam Chair. And I just wanted to say, first of all, Representative Brand, thank you for bringing this bill. I remember it from last year, I think it was, and, it's really unfortunate that it didn't become law. And I just also wanted to remember that this was originally brought by your predecessor, Representative Clark Johnson, and I know that he was, was very, very disappointed that it didn't become law. So I just wanted to say thank you. I think it seems like an entirely reasonable thing to do, and appreciate that the family, the Johnsons, are willing to come again to get this done. And I think by being here, especially on this very snowy day, that you're helping probably a lot of other families as well. So thank you for bringing this to our attention, and I hope that we can get this done this year.
Representative Albright.
Thank you. Bailey? Do you wear a bracelet?
Yes.
And so is that specific to her condition, or does it notify the paramedics of what condition she has, and is that going to be part of Mr. McAlpin's suggestion about how we work out? Because if you or your husband are both incapacitated, such as you described in a car accident, how will they know what to do for Bailey if she's not able to explain herself, or you for her?
Bailey's condition is marked and labeled on her ID bracelet, and then her number of her primary care doctor at her endocrinologist. And then in her bag, she also has an emergency care letter that her endocrinologist wrote up with detailed instructions on how to treat Bailey.
Thank you.
Any further discussion? Okay. Representative Pearson.
Bailey, I just want to say I love your bag.
Did you want one?
So, you know, we always have great testifiers in here, but no one has been any braver than you, Bailey. You came in, you testified, and you just did a great job. I want to thank you for doing that. Very brave of you. So there being no further discussion, the chair renews a motion that House File 85 be recommended for placement on the general register. Thank you so much, and good luck. So, all those in favor of the motion, the chair renewed motion on House File 85, please say aye.
Aye.
All those opposed? The motion prevailed. Thank you so much. All right. So our next bill, House File 831, Representative Halverson. So again, the chair moves that House File 831 be recommended for re-referral to the Committee on Judiciary. We have the bill before the committee. Welcome, Representative Halverson. Please present your bill.
Thank you, Madam Chair and members of the committee. House File 831 is a bill to update and modernize Minnesota's Health Records Act. The Minnesota Health Records Act was passed many years ago, I want to say in the 80s. And we are in need of an update. It was passed before the days of modern record keeping, electronic medical records. And the restrictions that Minnesota has are restrictions that 48 other states do not have. And so I bring this bill before you with bipartisan support because this is one of the most important things we could do this year to have an impact on healthcare costs. One of the biggest impacts of the way that we notice health records and exchange patient data for treatment, for payment, or for healthcare operations, as we do under HIPAA, having another layer of Minnesota law actually has an impact of having us duplicate treatment on people. One of the examples that I give is that I had a sick child who had to move from one healthcare system to another because there are very few of the pediatric specialists that he needed to see, and they after drawing lots of blood from my kid and doing imaging on my kid, we had to go to another healthcare system and do it all over again so that he could get prompt care. That was hard to watch as a parent, and we hear that from patients all the time. Again, my bill only covers treatment, payment, and healthcare operations. So these are activities that are specifically defined under the Federal Privacy Act, HIPAA. It's better known as HIPAA. And these are activities like quality assessment, care management, accreditation of facilities and providers, and then fraud and abuse detection. There's a lot of ways that we communicate through the system to work with patients and make sure that we're providing treatment for patients. I think it's incredibly important to note that the standards of HIPAA are exceptional and are well followed throughout the state of Minnesota. This is not a free-for-all for folks to share data on any single one of us. Data is only shared if it's necessary to facilitate our treatment, if it's necessary to facilitate our payments, if it's necessary to facilitate case management, quality assessment, and those kinds of things. Nobody is going to be able to access your data without the need, and that's one of the standards of HIPAA. It is the minimum necessary when they access data. And the federal law has standards in place to protect patient records. There also is security in place that governs patients' records under the HIPAA Act. There are certain exemptions to the Minnesota Health Records Act, and this simply adds an exception to the law as it is written. And I think that the most important thing to recognize is that this is something that the healthcare system in general has been talking about and looking at for a very long time. There are, I think that there's a letter in your packet, I hope that there is, that shows the support of healthcare groups, healthcare providers, the Minnesota Medical Association, medical equipment services, community health centers, chemical dependency treatment centers, the Brain Injury Alliance, the Chamber of Commerce. The list goes on and on, but it's a very broad group. And I think that anytime that an issue brings people together like this for the purpose of serving Minnesotans, that's a really good indication of the need and the necessity of the bill. And that is my introduction to the bill, Madam Chair, and I know that there are a number of people who wish to testify.
Thank you, Representative Halverson, for that. We have several individuals who would like to testify. I will call you down in fact, at least in twos. So please state your name and give your testimony. David Thorson and Mark Berman. Thank you. Welcome to the committee. Please introduce yourself.
Madam Chair and members of the committee, my name is Dave Thorson. I'm a family physician at the Untitled Clinic in White Bear Lake. I join you today on behalf of the Minnesota Medical Association to offer the MMA's strong support of House File 831. As a physician, I've seen firsthand how conflicts between the MHRA and federal standards impede timely, coordinated care, cost-effective care, and actually put patients at risk. I can share some brief scenarios where this happens. Imagine a patient with dementia who was just discharged from a hospital outside of our practice area after being there to stabilize their behavior on medications. They come in to see me. I don't have their records. I don't know what their medications are. And unless they've signed a consent at the facility at the time of discharge and a consent at our facility to obtain those records, we can't get those records. And we have to rely on a demented patient's history or their family's history, which may not be accurate. Mental health care, another area. Medications that psychiatrists are doing, inpatient psychiatry. Patients are hospitalized all over the state, as you're aware. We have teenagers who are suicidal who get hospitalized in Duluth, Minnesota, South Dakota, North Dakota. When they're discharged, we don't get access to their records unless they've signed a release there and a release at our office. Imagine trying to evaluate and treat a patient that comes into your office on psychotropic medications and we don't even know what they're on. Post-hospital follow-up. I had a patient who had angina, heart pain in northern Minnesota, was hospitalized in Duluth, and because Duluth doesn't know who Entira is, they didn't ask for release of records so they could communicate with Entira. I couldn't get access to her angiogram or any of those things to really help her get the care she needed. These are just 3 short stories that happen on a daily basis in our practices. Health privacy protections are vital to foster effective physician-patient relationships by ensuring the patients can be candid with their physicians. And physicians take the charge to protect their patients' privacy very seriously. Privacy regulations, however, can erect barriers, as I've discussed, between patients and their physicians and undermine patient care by restricting access to timely and accurate information. Under the MHRA, patient information may not be shared or received by a physician in most circumstances without explicit consent. Although intended to protect patients, in reality, the requirements can often harm patients more than they help, resulting in duplicative tests, as you heard earlier, rescheduled visits, unnecessary delays in treatment, and medication errors. The discrepancy between state and federal privacy protections can delay and complicate patient care. Patients at nearly every point of the healthcare delivery are having their care compromised. These complications are particularly problematic for those patients with complex healthcare needs that go across healthcare delivery systems. Patients with these complex conditions often receive care from physicians in multiple specialties across the state of Minnesota. And because of the different specialties with different healthcare systems that have different electronic health records and do not understand how to get records back to their primary care providers. And even those patients who want and expect their medical records to be available to providers often don't realize the barriers that are being placed on them. I have patients every day saying, what do you mean you don't have that record? What do you mean you can't get that information? How come? In this day of electronic communication, you can't find out what happened to me in Duluth? You know, they don't understand that it is the restrictions of the state that is preventing us from getting that. Similarly, the MHRA is currently constructed also complicates care in long-term care settings where physicians and social service providers are called on to coordinate a wide variety of services for their patients and clients. The MHRA hinders care coordination by preventing timely information transfer, forcing social service agencies and physicians to focus on administrative tasks at the expense of helping Minnesotans to live well in their homes and communicate. In both of these scenarios and more, the MHRA adds delay and burden to an already complex healthcare system, all to the detriment of patients. House File 831 will address these concerns by incorporating the protections of HIPAA into Minnesota law, modernizing the MHRA to work with the realities of Minnesota healthcare system. If passed, Minnesotans will receive better, coordinated, and safer care while continuing to enjoy the protections of the MHRA and HIPAA and existing data security, transfer, and access protections afforded under federal law. Minnesota physicians are dedicated to providing quality, timely, and respectful care rooted in strong, trusting physician-patient relationships. Our code of ethics compels us to maintain patient privacy, and we take that mandate seriously. House File 831 will allow Minnesota physicians to provide ethical and quality care while reducing outdated and burdensome requirements. The MMA strongly urges the passage of House File 831 to rectify weaknesses in the MHRA that create barriers to timely, coordinated, and cost-effective care. Thank you very much for your time and attention. I'm happy to answer any questions that members may have at this time.
So, Representative Lawson.
Well, thank you to the witness. I think the current law actually tries to address the situation. I don't think anyone has a problem about sharing information for the current treatment of the patient. The only limitation in current law for exchanging information for current treatment is within related healthcare entities. And if we were to take that away so that you as a physician could gather and get access to information from anyone when it's necessary for the current treatment of the patient, would that solve the situation you're in? Right now, it's limited to related healthcare entities.
Dr. Thorson.
Madam Chair, when you look at the importance of coordination of care, it goes across multiple agencies, and it goes into past things as well. So we have people with past hospitalizations that impact their current care. So the coordination of care part that HIPAA allows for coordination of care is a broad thing, really helps us do what we need to do to coordinate care for that patient across a continuum of delivery systems.
Madam Chair. I think the author would like to respond.
Representative Halverson.
Thank you, Madam Chair. And I just want to be crystal clear that there is nothing in either the federal or the state law that allows anybody to go gathering information. Everything has to meet a need-to-know standard. And I have seen the HIPAA guidebook, and it is thick, and there are, every agency, I believe, has attorneys that are helping with the compliance of this very complex law. So you can't go digging for data, you can't go mining for data. You can only get what you need to know to treat the patient in that situation.
Well, thank you, Representative Halverson. I'm just looking at the current language, which says for the current treatment of the patient, which I totally agree. We ought to make sure that the information is available there and without limit based on what entity you're contracted with or anything else. But the House Research Summary says that if we were to adopt this as broadly as it's drafted, that the information would be allowed to go to healthcare clearinghouses, healthcare providers, their business associates, and there's some other material in our packet that defines others other than the people who are actually involved in care. And that, if other witnesses, as they're coming forth, could talk about why do these other business entities need to have access? Because I have seen consultants, when we've seen reports in Minnesota about the unintended potential release of patient information. I can remember one, it was a consultant to a major hospital who's had the information about patients on their laptop, which was stolen from the trunk of their car. And they were doing some kind of research or study. It wasn't related at all to the care of a specific patient, but it required a notification of a lot of patients that private information about them may have gone out. And so I just really like to understand, because I do want to make sure that it's available for treatment. I'm just trying to understand the business associates and what that means.
Okay, Representative Dr. Thornton, who would like to respond to that question?
Well, I can do the 10,000 feet, and then the doctor can
Representative
give us the day-to-day if that works. But I think you bring up an important point of clarification, Representative Loeffler. Nothing in this bill changes the way that Minnesota protects data for study. And so research is not included in this. It is strictly for treatment, payment, or healthcare operations, which is defined as things like care coordination.
Dr. Dorsey.
Madam Chair, in most situations, people, when they sign up for insurance, sign an agreement that the insurance company has the ability to get this information. So that is not necessarily a change, because insurance companies have to know what was done in order to make payment for those processes. The incidents that you talked about where there was a theft of a laptop, that's obviously a horrible situation to have for patient data. But the person that kept the laptop that did not have an encrypted hard drive on their laptop and things like that, that's an error that's made. It would not change with this new law. It would still be the wrong thing to do. So this law would not allow access for a person to have data on their personal computer that is not protected.
Madam Chair.
Representative Halverson.
I have another person who's here to assist with the technical questions on the bill. I'm happy to say that he was able to come from St. Cloud, and so I wasn't sure if he was going to be able to make it. So if I may introduce him, and he can maybe shed some light as well.
Well, welcome to the committee, and glad you made it here safely. Please introduce yourself and share your
Madam Chair and
testimony.
members, I had to make a decision of whether or not to dress for the weather or the hearing. And I chose to dress for the traffic. There was a lot of folks that did make it into the ditch as I passed by. And I thought, I've testified in front of this committee and many, many others.
Could you please introduce yourself?
Santo Cruz on behalf of Centricare and the Minnesota Hospital Association.
Thank you.
So for those of you who are new to the legislature, or at least new to having me testify in front of you, this is new for me as well. This is the first time I'll testify without a tie on, probably the only time. But Madam Chair and members, to the question earlier, I believe what's being referred to is the Accretive Health lawsuit, where there was a laptop left in a car that was then taken and then led to a much longer investigation by the Attorney General at the time. And I'm glad it was brought up, because that is precisely what we're here to talk about in terms of the HIPAA standard. To be quite frank with you, is no joke. The lawsuit that went forward on HIPAA standards. And so if you recall, and I didn't represent either party at the time as an attorney or anything like that. I'm going off of memory and court filings. There was many, many counts by the Attorney General that were violated in state law when they brought the Accretive Health complaint on behalf of the people of Minnesota. The vast majority of those claims that moved forward and then led to basically a consent decree by the court for a settlement, that particular consultant would leave the state for a period of time, was on HIPAA and the high-tech standard. When that laptop was in the car, I think it was stolen like July 25th, 2011 or 2012. You can check me on that. When that was stolen, the reason why they got into trouble was because the information from about 23,000 Minnesotans was not encrypted as it's required in the HIPAA standard, not underneath the Minnesota Health Records Act. And the one claim, as I believe that I recall, that the Health Record Act was in the complaint, was that the stealing of it was an unauthorized disclosure that didn't have a signed, written, and dated authorization from 23,000 patients that it could be taken from that car. That's a breach under HIPAA, so it didn't add anything to the claim.
Thank you for that information. Appreciate it. Ms. Loeffler.
Well, thank you, Madam Chair. The question still to me is the business associates and for what purpose they need to know more than the current information. I understand billing information needs to be exchanged, but business associate can sometimes be broadly interpreted. It can be relationships with pharmaceutical drug salespersons who are tracking things. It can be, I think the concerns that I have heard from people are more about wanting past private medical information being widely available to anyone who has access to their medical record, and concerns about who would have access to the complete medical record, not their current treatment history and bills. They understand there has to be processing done, but I have heard from people who are really concerned that someone who's treating them for hammer toes or something doesn't really need to know what their mental health history or drug treatment was in their 20s or something else that they feel is very sensitive and may not have shared with other people in their lives.
So we're going to go to the next testifier. You really need to respond.
Madam Chair, I think it's a really important piece of the questions that surround how our data is used, and I think that it would be good to have an understanding to move the discussion forward, if that's all right with you.
The piece that's in discussion right now is Section 1 of Subdivision 5. It's the language in Subdivision 5 of the bill. Please.
So, Madam Chair and members, to address 3 quick points on that, because I do know that there are people who are scheduled to testify and traveled here as well. First, the BAAs in terms of, the concern, and I think that that's a valid concern that, you're worried that it could be willy-nilly, or how do you wrap your arms around who's a business associate? Under HIPAA, you have to have it documented through a contract. And under the High-Tech Act, which modified HIPAA, not only is a covered entity that is subject to HIPAA responsible for the compliance of HIPAA, by contract and by necessary documentation of that, they pass down some of that liability, compliance, and even penalties to their business associates in writing. That business associate has to document that they're well aware of the rules that apply to them, that they will make notifications if there are any breaches, and that they're on the hook if they violate HIPAA. Further, in those circumstances where breaches occur, not only is the business associate now under the federal law on the hook, the covered entity that entered into the contract with them can be held accountable as well, to add an increased incentive for covered entities to take very close looks at the type of relationships and liabilities they're adopting by contract with business associates. You mentioned 2 other quick things I'll just hit very, very quickly. You talked about, I think you said something like a podiatrist who would hear about mental health or drug treatment. Drug treatment is an entirely separate piece of information governed by 42 CFR Part 2. 42 CFR Part 2 means that any drug treatment information is not affected by anything we're doing today. In fact, it doesn't even live in HIPAA. Treatment information is what we call double top secret under 42 CFR Part 2. A provider that would be seeing someone would not have access, even under HIPAA, to that information about drug treatment or drug assessments if they took a step towards treatment. Mental health, mental health providers themselves have the ability under a separate statute in Minnesota to withhold information if they think that information will be detrimental to the client. So for example, if a doctor, a podiatrist, I don't know why a podiatrist would request mental health information, but let's say it happened, the provider, the psychiatrist, could then say, under Minnesota law, I can withhold this information from you because I think it would be detrimental to the patient.
Okay. Mr. Berman. Please introduce yourself.
Thank you, Madam Chair and members of the committee. I'm here in support of House File 831. I'll tell you a little bit about my background, give you some examples and why I support the bill.
Before you do that, could you please introduce yourself?
Yes, Mark Bierman from Prior Lake. I've lived in the South Metro area for 30 years where I've maintained my primary health care. After coaching a youth baseball game, my wife said to me, something's wrong. You look awkward running, especially when you ran from home plate to the dugout after warming up your pitcher. She said I needed to go see my doctor. So I went to see my doctor, and she ordered a number of tests, which led to a chain of out-of-network specialists, and in turn led to the University of Minnesota, where I was told I had a rare disease, a form of ALS. Unfortunately, a genetic test revealed it was familial, and with 2 children, I was motivated to fight ALS. That led to a clinical trial through the University of Minnesota's cooperation with San Diego. In fact, I leave Friday in 2 days for my 16th trip since May for another spinal injection. I think it's important to note that because of my background and my primary care in the South Metro area, and with all the specialists I've seen, I've constantly been keeping my primary care providers, the University of Minnesota specialists in the neurology department, and my research in California up to date on all of my medical changes. I said I'd give you a few examples, and I know I'm running late. I'm going to brief over one and just get in the other two. On one of my routine physicals I had, a question came up on a blood test. My doctor looked at it and said she was concerned. I said, you know, I had a genetic test. And she said, oh, really? That would be helpful. Let me see if I can pull it up. She went on the system, I believe it's called Epic, and she saw the data of my test, but she couldn't actually pull the data. And we both were puzzled, and we just chucked it off to a technology glitch and decided to hold off and do a test another day. But after being asked to testify here today, I did some digging and I made some calls to people. I don't even know who I'll talk to anymore, but I was led to believe and wonder if our privacy laws push us to the bottom when new updates come out. Do providers who work for our state and many other states push Minnesota to the bottom because we are an exception? They want to roll out all of their updates, deal with the 48 states that are compliant, and then deal with Minnesota. I also had another issue when I went down to the Mayo Clinic, and my doctor at the University of Minnesota actually was supportive of me to get a second opinion. But before I went down to the Mayo Clinic, I was told by the Mayo I had to hand carry and deliver all of my medical records. They weren't going to accept any electronic format or anything. I had to go out, and it took me forever. Now, as someone who has a rare disease, you seek answers from different specialists, and it took me 2 to 3 weeks. And carrying a stack of paper this big with CDs and everything else to the Mayo Clinic. I was reminded of that just this last week when I reached out and I spoke to a person who was recently diagnosed with ALS. And we talked about a number of different things, and he mentioned something similar, and he said, Mark, the same thing happened to me. His daughter worked in a medical system not far away, and she said, I'll help you get into the Mayo Clinic. The Mayo Clinic would not even open up the records because of our privacy laws, and it was so bad, and he was so discouraged, he decided not to seek a second opinion. Finally, email. I said I was in San Diego quite often, and my doctor and my research out there are always concerned, and they were concerned about a
a heart condition that appeared on a record. My doctor said we'd like to have your primary care physician take a look at it and make sure they also agree that it's nothing too serious, but we want to make sure. So I asked my doctor if he could email me the scans. He did. I called my primary care physician, and they're the clinic, and they said, no, we can't accept email copies. And I was, I guess, astonished that in our day and age, I could not email my own medical records to my primary care clinic to have them look at it. And I was left wondering whether or not that was something serious, and if it had been, if our privacy laws would have cost me my life. So I support this bill because, number one, I believe in our legislative process. I advocate for the ALS Association and rare diseases, including my 5 trips to Washington, D.C. I've seen how much analysis and detail is brought into passing laws like HIPAA on a national level. 48 other states have adapted HIPAA as their standard. I'm now experiencing that in another state on the West Coast, and I can see how much easier it is for me to share and to get information from my doctors in California. In the last 10 months, I've talked about this issue with many people, and I cannot think of one person that said that we should be against passing this bill. So in summary, a rare disease has shown me how great our healthcare system in Minnesota can be, but our privacy laws make navigating through our structure very cumbersome. Some just give up. Let's hope it's not life-threatening. You have the power to change this for all Minnesota residents, and I urge you to do the right thing and pass House File 831 and strike that balance that permits important, efficient uses of medical information and allow us to get proper care when we need it most. Thank you.
Thank you. Bentley Graves and Sheila Phelps.
Madam Chair, while they come down,
Representative Halverson.
I just would like to take a moment. I think maybe he's gone, but my co-author, Representative Zerwas, was here. He's carried this bill in the past, and his work on this, I just really appreciate it. I wanted to highlight that he came in for the hearing as well.
Welcome to the committee. Please introduce yourself.
Thank you, Madam Chair. My name is Bentley Graves. I'm with the Minnesota Chamber of Commerce. And I appreciate the time to testify today. I appreciate Chair Halverson bringing this important legislation forward. You know, from the employer perspective, which is the perspective of our members, when it comes to healthcare issues, cost is very much a top-line issue. And when it comes to efforts to try and take costs out of the system to lower costs for employers and their employees, it's typically a conversation that comes with 2 very clear sides. You know, somebody asking to take costs out of the system, and that cost coming out of the pocket of somebody at the expense of somebody. What I want to make sure to highlight today is the list of supporters behind this legislation. This is supported by those of us in the business community who represent employers who largely pay the bill for healthcare, but it's also supported by those who work in the healthcare system, doctors, hospitals, health plans. It's also supported by patient advocacy groups, the folks that live every day in the healthcare system. And the reason why is because it's a common sense way to bring costs out of the system, unnecessary costs out of the system by reducing duplicative tests, medication errors, rescheduled trips, without bringing any harm to the system. And in fact, bringing better care, better coordinated care, better patient outcomes to patients. And so I appreciate the opportunity to bring this message of support on behalf of the business community for this legislation that we believe will reduce costs for our members and their employees, but again, does so in a way that brings broader benefits to the entire system. And so I again appreciate Chair Halverson bringing this forward. Appreciate all the work that's gone into this from all the supporters of the bill, and I'm happy to answer any questions you may have.
Thank you so much. To the next testifier, please introduce yourself.
Hello, Madam Chair, members of the committee. My name is Sheila Van Pelt. Unfortunately, I'm testifying against the bill. And the thing is, I'm just going to say this. There's so many times many of you in here all agree with what this person says and I'm behind their bill, or I'll agree with this person behind their bill. And this is one that I want to throw the cautionary tale at. This bill really has to do with the pride we have in our data practices laws in the state. We are a standout. Much work and has been done through the years by the civil law and data practices as well as judiciary. And it's one I look at and I'm so proud of. What this comes down to is looking between privacy and consent. And the consent part is of utmost of importance to many people. Do we have our consent to have our records going around? And the proponents of the bill, and I will look at it, there's so many great things about what the bill does on that, in efficiency and convenience, but what we aren't addressing is the idea of control. Who controls the data? Who gives up the control of their personal, private, most intimate information? And do they want that? Are we taking it away from them, their say? And Representative Loeffler, when she was here, spoke to that I'll say thank you. There are costs, some of them intended costs that are there, and unintended costs. And I will say in Europe, many different enactions are being done and taken recently. For instance, there's a quote unquote for an article, the EU hits Google with a fine of $5 billion for pushing apps. And as also in the New York Times, tech giants brace for Europe's new data privacy rules. They are seeing that they need to increase their privacy. And here in the state, we are a leader already. The unintended consequences are the data breaches, and they are real. And in the state, I've heard testifying from our IT departments, it's not a matter if we don't update our data, it's not a matter if that data is going to be breached, but when. And we just can pretty much look every day and find data breaches. And I'm not sure, I feel comfortable with every aspect of my personal care being breached and out there. Another area is that Representative Loeffler spoke to was a third-party vendors or bills. Now, it testified last year in a Judiciary Committee was talking about bill collectors. And I believe it was Fairview Systems that was reprimanded for their work done in an unsavory way of harassing patients for collecting bills but having access to information. So with the control in this state, and privacy, I'm going to just throw you on the caveat of things. This seems to be what works for one side more than for the other. And an example of just when we hear the words of leveling the playing field, I look at areas that the provider groups, the HMOs, don't want to give up. They're asking us to give up our most private information. But for example, in this state, we don't even have access to looking at the paid claims data of Medicaid funds in the state to even know what those costs are and if they're accurate. We take people at their word, the HMOs in that matter. Another thing is let's just say now patients are wanting to get access to what are the costs of medical procedures. It's pulling teeth to even know that patients have that right. And lastly, too, in another area, when you want to make a complaint against your HMO provider, that too is garnered as being private information and you don't get to know. So there seems to be an idea of control that doesn't really work so much in the consumer's end as much as what is being protected and coveted by those who want to maintain control of things that they called secret, proprietary secret. Also another area I'll just say is PBMs in another cost driver that we don't seem to be looking at. So what I want to look at is when we have transparency and accountability and efficiencies being built into this, we need to look at our system as a whole because there are so many other different drivers into the cost of our healthcare that isn't being looked at or being cared about. And just to really hold tight to people's wish to consent or not consent to their own personal data instead of deciding it for them. Thank you.
Thank you so much. Joseph Olson and David Finwa. welcome to the committee. Please introduce yourself.
Yes, Madam Chair, members of the committee. My name is Joseph Olson. I'm a professor of law emeritus at Hamline University. I'm here, of course, today speaking on myself alone. When I was in law school, my first semester, we had to write a legal memorandum. It happened to be on informed consent. So I'm one of those people who reads these documents that I'm given whenever I go into one of the medical care providers. And you know what? Every one of them has in this document a consent that makes this law unnecessary. And I read it over and I go in here and I find, well, I don't mind if you share it for treatment. Matter of fact, I'd like you to do that. I don't mind if you share it for payment because I'd like my insurance company to pay. But I'm not letting you have it for healthcare operations because I don't know what healthcare operations is. And last year, House Research wrote a nice little précis on what's going on here. Here's the paragraph. While it is not known exactly how many entities may have access to a patient's private health information, it is possible to know the types of entities that could potentially have access to it. In general, covered entities and their business associates are permitted to receive it. In 2010, HIPAA issued HIPAA regulations, something rather, and listed more than 700,000 covered entities and 1.5 million business associates. Now that's almost 10 years ago, so double those numbers. Covers entities include health plans, healthcare providers, healthcare clearinghouses, and when we look into what business associates mean, it includes essentially anyone that a healthcare plan wants to have consultation with. Consultation over anything. They can take my data and say, well, we'd like to know, whether fishing increases the likelihood of having heart attacks. Well, they've asked me if I fish. They know I fish. They can take that information and use it. I may not want them to. Personally, I always check no on these things because I feel if somebody's going to get paid for doing research and using me, they can pay me for my sample. Part of that, I suppose, is because when I was at Duke, they were doing open heart operations in the late 60s, and they used whole blood that they took from donors within 2 hours of the operation. And I actually managed to put myself through law school with my right arm. But the fact of the matter is, they already have to ask questions that require them to keep track of data. Here's one place where you can say no, and if you say no, they have to keep track of it. Here's another place where you can say no. If you say no, they have to keep track of it. On the other side, it says, well, if you don't want to give us this information, you can say no, but it doesn't provide any place to do it. And last year we heard testimony that, well, you can't let patients exercise this right of consent because our $400 million computer system can't keep track of it. Well, the fact of the matter is there are patients like me out there who read the forms. There are patients like me out there who say, yes, I'd like you to have the information to treat me. Yes, I'd like you to have the information to get paid from my insurance company. No, I don't want you to have the information for whatever you want to use it for with you and your now 500,000 unknown entities doing unknown consulting and unknown research about God knows what. Thank God I live in Minnesota. I'm actually able to exercise my right to say no. If I live in another state, I lived under HIPAA, I wouldn't be able to say no. Remember, the bill you're passing says you can't say no. Now, I don't mind that with regard to treatment. I don't mind that with regard to payment. But I certainly do mind it, and I think everyone in Minnesota should mind it, with respect to healthcare operations, because it's just a huge blank check on your most personal, private information. So what I suggest is you go on page 1, line 13, and you take out "or healthcare operations." Because the gentleman over here doesn't care about healthcare operations. He wants his doctor to be able to have information for his treatment. Everyone who testified last year, and there were a lot more people, testified We want, and Sir West testified to this, we want treatment, we want treatment, we want treatment, we want treatment. Yes, everybody wants treatment. That probably should be taken out. The doctor said, we want to be paid, we want to be paid. Yes, okay, fine. My insurance company will get the information and they'll pay you. But we want to take your information and throw it in the washing machine of research, consulting, selling of this, that, and the other piece of important information. If it's about me, you're going to pay me for selling it, or you're not going to do it. Thank you very much.
Thank you. Carrie Sheldon and Twyla Grace. Welcome to the committee. Please introduce yourself.
Madam Chair, thank you. My name is David Feinwachs. I am a resident of the city of St. Paul. I teach at the University of Minnesota, but I'm not here speaking on their behalf, for which they are eternally grateful. I am a lawyer, and I was for 30 years general counsel for the Minnesota Hospital Association, and I am here to speak in opposition to this measure, but not because some change isn't needed. As Professor Olson pointed out, for patient convenience, comfort, and effective treatment, some change to Minnesota law probably is justified, but not this. And I'm going to tell you why. The first and most important thing for you to understand is there's a difference between HIPAA and the Minnesota law. The Minnesota law allows you to sue. And if you'll indulge me, in 2009, there was a woman named Candace Yath who went to a clinic operated by Fairview. She made an appointment so that she could be treated for sexually transmitted disease. The medical assistants who saw Ms. Yath knew her husband. That person read her medical records, learned she had a sexually transmitted disease and a new sex partner other than her husband. She shared that information with other people and with plaintiff's husband, who the woman was separated from. And then someone created a MySpace page posting this information on the internet. Now, that's pretty egregious conduct. In fact, that's pretty crazy. They were sued. Fairview defended this lawsuit on two basic grounds. My favorite, the first defense, is nobody looks at MySpace. And that's probably a good defense. The second defense was that Minnesota's medical record law is preempted by HIPAA, because it is contradictory to and conflicts with HIPAA and is no good. In 2009, the Minnesota Court of Appeals ruled on that and said no, that is in fact not the case. The Minnesota medical record law is complementary to HIPAA. It augments HIPAA. It helps HIPAA out. It creates yet another reason to keep people honest and to keep information confidential, that reason being that you can sue. You can't sue under HIPAA. There was earlier some discussion about the accretive fiasco, which oddly enough involved Fairview 2 or 3 years later after the Yath case, because apparently the learning curve is steep. So in the accretive case, for which I was present, what happened in the accretive case is, accretive was a revenue cycle management company, which is MBA speak for a bill collector. Accretive was given with a HIPAA affiliation agreement the medical records of thousands of patients. I'm not talking about their name, address, and phone number and how much money they owed. I'm talking about their diagnosis, the drugs they were on, what was wrong with them, whether they had chemical dependency issues, whether they suffered from depression, whether they were being treated for sexually transmitted diseases, such as HIV or other things, okay? Accretive used that because they had algorithms designed to pressure people. Our Attorney General at the time ran Accretive out of the state, and Accretive paid some number of millions of dollars to the people that they had victimized. This was accomplished not using HIPAA, because under HIPAA, you can't sue. This was done using the Minnesota law that you're now being asked to change. And this is, in fact, an incredibly bad idea. We have computers that can keep track of who consents and who doesn't. And last year, this issue has arisen every year almost since 2009, because the people who don't like this law, and I'm not talking about the poor patients and the other people, the medical providers who don't like this law really don't like the part that allows them to be sued, and that's understandable. But it's that part that keeps people honest. It's that part that makes the system work. And as you can see, weird things happen. So it's your information. It doesn't belong to them. If you want it kept secret, you should have the right to have it kept confidential. If they breach that, you should have a remedy against them. If you want to change the law to allow it to be moved for treatment or payment, that might be okay, but payment has to be bifurcated, because I would defy, and I say that in the most respectful manner, any member of this committee to tell me why a bill collector company needs to have a patient's medical record, their drugs, their diagnosis, and their family history. So there is a way to fix it, but this isn't it. My recommendation would be that this thing be laid over until the Data Practices Committee that heard and considered this last year can come up with what I believe will be close to what I am just suggesting to you. So yes, there is a fix. And finally, I will leave you with this. All of you have sat on different committees, and you know we are in the midst of an opioid crisis, a terrible dilemma. And we need people into treatment. That's why we're trying to raise money, and we're trying to figure out what we're going to tax. We need to get people to receive treatment. Do you think they're more likely or less likely to get treatment if that information gets posted on MySpace with HIPAA affiliation agreements? Thank you.
Thank you, Mr. Feinwax. Chair Moran had to step aside, so as vice chair, I'm stepping in. Mr. Cruz?
Thank you again for the record. Santo Cruz, MHA and CentraCare today. Just to clarify 3 points real quick. We are not amending the private right of action. The lawsuit stays. So if you read the bill, to the last testifier's point about the Minnesota law maintaining an ability to sue, that does not change. So that it will still be a feature of our state law. I would just ask you to do your own internet research on the accretive issue. I don't represent Fairview. I've never worked for them. But you can look for yourself. There's a public complaint from our AG. Again, as I said earlier, the vast majority of that lawsuit was HIPAA. There was one thing that was the Health Records Act, and that was limited to, again, the 23,000 folks who sadly had their information stolen out of a laptop, did not sign a dated release for that to be stolen out of the backseat of the car, which is already captured by the breach definition on the federal level for HIPAA. So again, it didn't add anything to that scenario. And then lastly, about the opioid crisis. Again, I would ask you just to write down this jargon, 42 CFR Part 2. Anything we do here today is not going to affect how treatment information is shared. That is separately regulated at the federal level. We are absolutely required to follow that in Minnesota. And when it comes to drug treatment, it's not even in scope of what we're talking about. And then lastly, to the earlier testifier about what is business operations. It's one page I have in my back pocket. You can find it online. It's not an open book. It's very specific, and I would refer you to the definition on the Federal Register of what business operations are, and they're all predicated upon some other necessary process and other permitted use. This is not to vouch for or say that breaches don't happen. This is to say that there's adequate accountability in place for when breaches do. You can't pass a law that says breaches shall not happen. You can only pass a law that says when they do, what will happen. And people need to be held to account. The stories that have been told are horrific, and people were held to account as I understand it. Maybe not to the level they ought to have been, maybe not to the satisfaction of those involved, but there was a framework for accountability. I don't think there's any law that we can pass here today or that you all can pass here today that will make hackers stop trying to hack into IT, make people, bad actors, stop existing. It's about the accountability for when those things tragically do happen.
Thank you, Mr. Cruz. For our next testifier, please introduce yourself.
Thank you, Madam Chair. My name is Twyla Berets. I'm president and co-founder of Citizens Council for Health Freedom. I'm also a registered nurse and a public health nurse. And our organization has long been involved in protecting privacy and consent rights here and at the national level. We have 3 documents for you, which are going to be handed out shortly. One of them is the Mayo Notice of Privacy Practices, which I will discuss in a moment. The other is a definition sheet for those 3 terms: payment, treatment, healthcare operations. So you will be able to see for yourself the definitions. And then the last one are 2 local consent forms that have concerned us about how the Minnesota law here is actually being followed or not. So, and I also have 5 items for your consideration of House File 831. So here's the first item. The first item is that HIPAA is not a privacy rule. It is described as a permissive rule because in most cases, those who hold patient data, called covered entities, are permitted to share and use individually identifiable patient data without patient consent, unless a more protective state law exists, as it does in Minnesota. As David Brailer, the first national coordinator of health information technology, said about HIPAA, he said, "You can't force a covered entity to give your data to someone you choose, and you can't stop them from giving it to someone they choose," end quote. Under HIPAA, according to HHS, at least 2.2 million entities can potentially share and use patient identifiable data without patient consent, and that does not include government agencies. So the number is even greater. The second item, privacy rights are humane and compassionate. The pledge to keep a patient's information confidential goes all the way back to the Hippocratic Oath. Privacy rights shield patients when they are vulnerable and gives them the trust they need to speak frankly and access care timely. Privacy rights protect those with mental health issues, sexually transmitted diseases, addictions, cancer, infertility, and disabling genetic conditions. Privacy rights protect reputations, family relationships, and employment, and future aspirations. Minnesota's consent law honors the patient's privacy rights. HIPAA does not. HIPAA allows broad health information exchange, essentially putting it and making your information available through the internet. Consider that the Minnesota Health Information Exchange law has a clinical data registry. Look up the definition once. What it does is pull all your data together into one single view, one unified record for every individual. Under HIPAA, or under this bill, all that data would become available electronically to anyone the covered entities wanted to give it to. It wouldn't be segmented out. It would be the entire record. That's why a physical therapist called me once and said, you know, I know my patients, I can see their STDs, I can see all this sort of thing, and I know they wouldn't want me to do that, but I can. And so this is what can happen once we move to the HIPAA no privacy standard rather than the Minnesota privacy standard. The third item, the Minnesota legislature used HIPAA's state preemption provision to establish a better than HIPAA law, a real privacy law that requires consent in 8 areas. So if you're looking at the Mayo Notice of Privacy Practices, you will see red versus green. And in the red are 8 provisions where consent is required in Minnesota, and it is not required around the rest of the nation. All of that would be gone if this bill passes. This bill would undo our best in the nation, better than HIPAA law, and subject all Minnesotans to HIPAA's no privacy rule, giving outsiders a license to intrude. Specifically, House File 831 eliminates consent requirements for treatment, payment, and healthcare operations. So now you all have the definition sitting in front of you, and I just request that you look particularly at healthcare operations. It is a nearly 400-word list of at least 65 non-clinical business activities, and it could be more depending on how you count it. Even the Minnesota Department of Health admits that eliminating our current consent requirements, quote, may raise privacy concerns because of the broad scope of healthcare operations, end quote. Fourth, consider United Health Group's Optum Insights division, which has been described as a data and analytics, technology services, and healthcare operations business. Its 2007 revenues were $8.1 billion. No wonder corporate supporters of this bill want to exempt healthcare operations from consent requirements. There is much money to be made. And those healthcare corporations using the coercive consent forms like the ones that we have shared with you today, they would probably want this bill passed just to avoid being sued for violating our law. Because if you look at those forms, you'll see, for instance, North Memorial's form, where it says at the bottom, there's only one signature, and all it says is, not only do I agree to consent for treatment, but I agree to all the rest. And there's no chance to cross out all the rest. So that's coercive, and our law is about consent, and consent is not coercion. So, finally, protecting patient privacy protects patient control. In short, he who holds the data makes the rules. Using confidential patient data, payers can profile doctors, track and conduct predictive analytics on patients, intrude in private lives, and use the patient's data against them and their doctors. Therefore, we respectfully ask you to vote no on House File 831. Thank you.
All right, thank you so much. Do we have anyone else in the audience who have traveled from a distance who would like to testify on House File 831? Okay. We only have this room until 4:15, so we'll have to leave. But if members have some questions that we can maybe get through a couple of questions before we recess until the call of the chair, Chair Liebling.
Thank you, Madam Chair. We had some back and forth on this question of a private right of action, and I was whispering here with Ms. Clarkfist about that. I wonder if she could give us try to answer that or address that question for us as best she can, because I think it is kind of a critical issue to this.
So, Madam Chair and members, I guess what I would say is the private right of action is maintained related to the Minnesota Health Records Act. With the amendment to the Health Records Act in this bill, though, there wouldn't be a cause of action for not obtaining consent, because consent isn't required for the release for purposes for treatment, payment, or healthcare operations. That's helpful.
Okay.
Thank you.
Yeah.
Chair Liebling.
Madam Chair, thank you very much. So, I mean, what I take from that is that Mr. Feinwachs is essentially correct, that you're right to sue for dissemination without consent for treatment, for payment, for healthcare operations, whatever that means or doesn't mean, that would be essentially removed by this bill. So, I think that is true. I mean, I've for many, we're going to be out of the room in 5 minutes. I assume we're going to vote on the bill before we leave here at
That would be
5
great.
minutes.
We can do that.
So I just want to make a brief statement here. I've been long opposed to, I was opposed to the previous version of this bill that simply got rid of the Minnesota Health Records Act and had it all be HIPAA. And I think we're moving in the better direction here. I'm not opposed to any change to the Health Records Act, but I do think that what's being asked for here, for my sense of this, it does go too far. The author of the bill made a comment that there's a need to know standard, but I would say to members, which needs and whose needs are being considered here? I think that I recognize that having to ask for consent can sometimes be inconvenient. I think we've made some changes to this law over the years. I think I was here when some of these exceptions were put into the law, exactly because of the kinds of concerns that have been raised here by doctors and patients about wanting to be able to get treatment and not having our consent laws get in the way of treatment. And so I'm all for that. But the gentleman that spoke, Mr. Olson, Professor Olson, I think expressed it pretty well, how I feel about this. I get most of my care at the Mayo Clinic, and they have a kiosk now. You don't even have paper anymore. You sign in at the kiosk and they ask you for your consent. And I just don't really see that that's such a big barrier anymore. I also wanted to flag for members, I have an article here, which I'm not handing out, but perhaps I will in the next committee, but very recent study it's in the Milbank Quarterly, which is a very scholarly journal, just published at the end of 2018, and it talks about how there aren't Well, just one of the policy points they have on the front says, today, healthcare providers' complaints about legal obstacles to health information exchange may be better understood as reflecting concerns about the economic and competitive risks of information sharing. In other words, there may be, I certainly don't discount the concerns of the large organizations who want it to be cheaper and easier to do their business. I mean, that is a concern, and that's what they're saying here. But the actual issue about treatment or being able to do the business of healthcare is actually less of a concern than it's made out to be when this bill is brought forward. So I am certainly remaining a no on it at this point, and I just wanted to explain that. And if somebody comes forward and makes it easier to exchange information for treatment purposes, I'm all for that. But I don't think it's so difficult right now to, I just don't think we need to go the route of allowing information without consent for treatment, payment, or healthcare operations. That just seems to me to be a bridge too far. Thank you, Madam
Okay,
Chair.
really quick, Representative Morrison.
Thank you, Madam Chair. I'll be quick.
How much did you need? We have 3 minutes.
Thank you, Representative Halverson, for bringing this bill forward. As a physician, I think it's an excellent bill, and I think it's a change that we need to make. I can tell you that it is I also take, as Ms. Van Pelt said, take great pride in the fact that I believe it was Senator Limmer who originally did the Minnesota Health Records Act, and we should be proud of that in Minnesota. But it's become redundant with the changes of HIPAA, and it absolutely acts as a barrier to patient care, in my experience as a provider. So I will be a yes on this, and I hope everyone else will be too. Thank you.
In saying that, personally, I remember those days of having to go from one location to manually pick up your medical records and take them from place to place. I thought it was a headache then. I think it was a headache now. I appreciate going into the office and my medical doctor can see my information from 5 years ago, 10 years ago, and it's available and it's there. One of the things that I have not seen in the testimonies, I know we have fears about privacy, and I think we all know that privacy is hugely important, is that that there has not been any violation under the HIPAA laws. I have not heard that. Yes, we heard of a computer that was stolen out of someone's vehicle, and that's, as you stated before, it's not so much under the regulations of HIPAA that was in fault. I believe that's what I heard from you. This is one of these bills that can be very controversial, that we can really have our fears come to a level of, our decision-making, whether or not we believe that, Minnesota is one of a few states that have this extra step in the way that gets in the way of hospitals and doctors doing their work. And so I'm going to end by just opening this up for a vote. There's no further discussion. I would like to renew my motion that House File 831 be recommended for referral to the Committee on Judiciary. All in favor say aye.
Aye.
All opposed?
No.
Motion prevails. House File 831 is recommended for referral to the Committee on Judiciary. We are adjourned. I'm sorry. I take back that. We are in recess into the call of the chair.